Assalamu alaikum everyone. I'm Dr. Sadia Noor, former Joint Secretary PSA, and I welcome you all on behalf of PSA to this online lecture series. And we have been joining after quite a gap. So we have with us Professor Dr. Amin Khuwaja, and he is consultant anesthesiologist at NICVD, and he is working as a professor, head of the department of NICVD, and also he is a member of FECTA and former president of FECTA. So the topic for today is anesthesia for patients with cardiac devices. To mention all of you that we will be delivering this lecture in English, and all the mode of conversation will be in English because we have international participants as well. All of the participants are requested to please keep your mics muted and keep your videos off, so that there's a smooth delivering of the lecture. And if you have any questions, you can comment in the chat box. We will take them one by one at the end of the lecture. So now I will hand over to Dr. Amin Khuwaja. Sir, please.
Thank you very much. Thank you, Pakistan Society of Anesthesiologists, Dr. Sadia, Asma, and all the office bearers for continuing this online lecture series and inviting me for this very important topic. Can you all hear me? Can you
yes,
hear
sir,
me?
we can hear.
Okay.
Yes, sir, we can hear.
Okay, so I'll be talking on the anesthesia for patients with the cardiac devices. I'll be just focusing on the pacemakers and CIDs. So, but I will let you know what other devices which are being used. So, safe anesthesia for patients with the cardiac implants is a growing challenge. So, I will just present a scenario, and then we will discuss the pacemakers and ICDs. 65 years old male with a symptomatic cholelithiasis is scheduled for the elective laparoscopic cholecystectomy under general anesthesia. He has a history of complete heart block and has a permanent dual chamber pacemaker implanted 3 years ago. The patient is otherwise hemodynamically stable with a controlled hypertension. Now, these type of patients comes to in your practice. Either they, in this scenario, I have just wrote a permanent dual chamber pacemaker, but this could be a patient with an CIDs. So what the questions you have to address before proceeding to the theater? So how would you assess this patient preoperatively? We'll try to answer in the coming slides. What are the anesthetic concerns in patients with a permanent pacemakers undergoing laparoscopic surgery or with ICDs? How would you manage the pacemaker intraoperatively? What post-operative care is required for this patient? So these things we will be covering in our lecture. Now, this topic is also important for the examining candidates and the practical working anesthetists to address while these type of patients come in their daily practice. So once we are talking about the cardiac implantable devices, that includes pacemakers, which I am going to talk about, implantable cardioverter, defibrillator, ICD, CRTs, cardiac resynchronization therapy, and the ventricular assist devices. So I will not be focusing on these two, but I will show you one slide regarding the cardiac resynchronization therapy and the ventricular assist device. Just I can tell you, this is to support the left ventricle, and this is implanted when the patient is on the heart-lung machine, and then this is used. Once it is implanted, patient has got the 2 batteries, and each battery goes for the 12 hours. So, but this is not the scope of today's topic. So I'll be focusing on the pacemaker and ICDs. So the pacemakers are inserted as a treatment for the heart with a dysfunctional intrinsic conduction system. The pacemaker program electrical impulses to the heart for stimulating myocardial contractility. Once we are talking about the pacemaker, that can be a temporary or the permanent. Once we are talking about temporary, that could be the transvenous or the transcutaneous. And the permanent, which I will be talking in our coming slides. All right. So the class 1 recommendations. So these are the recommendations from the European Society of Cardiology Guidelines 2021. The class 1 recommendation is symptomatic SA node dysfunction, third degree AV block, second degree type 2 AV block, permanent AFib with the symptomatic bradycardia. And the class 2 recommendation is symptomatic chronotropic incompetence, symptomatic first degree heart block or the second degree type 1 block, syncope or the unknown origin with the sinus dysfunction. So these are the recommendations. That was the European Society, but the American Society, they recommend for the symptomatic sinus bradycardia, symptomatic chronotropic incompetency, and the symptomatic sinus bradycardia resulting from the medical drug therapy. So pacemaker comprises of the three main functional components: pulse generator, lead, and the electrode. So I'll be focusing on all these three components very briefly. The pulse generator is the brain device. In case under titanium cover includes the circuit that can generate an impulse and sense intrinsic electrical activity. Battery which can last up to the 10 years depending on the manufacturer. Size of the pulse generator is normally in the Pakistani 1 rupee coin or the American quarter coin. It is implanted between the subcutaneous tissue and the pectoralis major muscle. The weight can be as light as 9 grams. Then the leads, you can see these. I'm just focusing on this. These are the leads. Leads are insulated wires, 1 or 2, that connects the electrodes to the generator. They pass through the central vein. The aim of positioning the tips against the myocardium of the targeted chamber. The leads propagate stimulus from the generator to the heart and relay intrinsic myocardial signals back to generator. Then the electrodes located at the tip of the leads. You can see these are the tip of the leads. Electrodes are there. They are the positive and the negative, anodes and the cathodes. The voltage which is propagated along the leads depolarize the myocardium, generating an impulse. These electrodes also function as sensors by recording intrinsic electrical activity. Now these are the North American electrophysiology pacing group and the British pacing and electrophysiology group. So that is combinedly called as the North American and the British group. So they have labeled the pacemakers in the 5-letter positions, and these documents are reaffirmed every 5 years. So this last is documented on the 15th March 2023. So you can see there's the 1, 2, 3, 4, and 5. You can see on the screen. The first one letter identified chamber pace. That is the atrium, ventricle, or the pace atria and ventricle both. Second is the sense, same atrium, atria, ventricle, and the both or none. Then third, response to the sensing. Either it is a triggered, either inhibited, or dual trigger and the inhibited, or it's no responsive. Then fourth one is the rate modulation, none, or rate modulation. You will find in the letter VVIR, VVO, VVOR. So that signifies a rate modulation. I'm going to explain in the coming slides what does it mean. Then the multiple site pacing, none, atrium, or ventricle, or dual, both. So modes of setting on the setting of the pacemaker. As I said, the first letter is the chamber that is spaced, atrium, ventricle, or the dual chamber, both. Second is the represent the sense chamber, atrium, ventricle, dual, either it is an inhibition or trigger or no response. Third is the response to the sensing. Either there's no response, you will find in the few letters VVO or VVT or VVI or VVD. So that signifies zero means none, no response to the sensing. T means the trigger and I means the inhibited or both triggering and inhibition. The fourth is the rate modulation that basis rate changes based on the perceived physiological need of the time. Zero or if the patient's heart rate increases during exercise, that will be accommodated. And the fifth letter, which signifies multi-site pacing, pacing from the atrium, ventricle, dual chamber, or the nerve. So inhibition means the pacemaker does nothing, and trigger means it paces or fires. So now we are going to, I'm going to talk about we said either the first letter which identifies the pacing. So you can see VOO, it means the pacemaker paces the ventricle at the fixed rate without sensing the heart natural activity. Now this VO is done intraoperatively to avoid the electromagnetic interference. I will talk in the coming slides also. This is done intraoperatively, so the sensing is not interfered with by the diathermy or other form of the electromagnetic interference. On ECG, it is identified by spikes after the P wave. So it is very important to understand the ECG and the pace and the X-rays. I will show you in the X-rays. If you don't have the patient is not bringing an proper detail about the ICDs or the pacemaker, so you can just look at the ECGs and the pacemaker. You can identify what type of the mod is on the patient is, and either it is a pacemaker, either it is the ICD, either it is in a CRT. I will show you in the coming slides. Then is the AOO, the atrial pacing, no sensing, no response. This pacemaker paces the atrium at the fixed rate without sensing the heart natural activity. So this mod takes advantage of intact AV node and other conducting systems. So only the atria, if the problem is in the atria and the ventricles are fine, so that will trigger the atria, but the AV node and the other conducting system will be intact. Then when VVI, so first letter signifies ventricle is pacing, second signifies the ventricle is sensing and inhibited. So ventricle pacing, ventricle sensing. So single chamber pacemaker in the ventricle pace ventricle, sense ventricle, inhibit if heart beats. This is the basic pacemaker. And then the AAI, atria is pacing, the atrial sensing and inhibited. The pacemaker paces the atrium only when the heart natural atrial rate falls below the set threshold or sixth sinus syndrome with the normal AV node. So again, when there is a problem with the atria, so the pacemaker will pace and the sense, but the remaining the ventricles will be on functioning normally. Then the dual chamber pacing, dual chamber sensing, and the dual response means it is triggering and inhibited. So pacemaker can pace and sense both the atria and ventricle, inhibit or trigger as needed. If both SA and AV nodes are functioning, then the pacemaker will not just sense. The patients with a combination of sinus node dysfunction and AV block benefit from this mode. Then the dual chamber pacing, dual chamber sensing, and there's no response. So similar to the DDD as discussed in the first one, but the pacemaker does not track atrial activity to pace the ventricle. The dual chamber pacemaker mode that paces both atria and ventricles while also sensing both the chambers. Now, these, as I said to you, the fourth alphabet signifies rate responsive. So, patient has got the DDD and the rate responsive. If the patient is walking or exercising, if the rate goes up, that will be adjusted. Or if patient has got the VVI, hello, please mute the voice. Who has got an? Please keep the mod on the.
All of you are requested to please mute your mics so that we can listen to the lecture. Thank you.
So VVIR is the rate responsive for the patient with the AFib. If the patient has got an atrial fibrillation, then the VVIR mod. The fourth one, as I said to you, that is the rate responsive. Now the pacemaker syndrome, that is also asked in the exams, also on the table, or sometimes in the MCQs, or so pacemaker syndrome is the commonly seen in settings of the single chamber device with a ventricular sensing and pacing lead, the VVI mode. This mode has no atrial sensing lead to guide the ventricles. The ventricle contracts at the programmed rate regardless of timing of atrial contraction, leading to loss of AV synchrony, which leads to loss of stroke volume and cardiac output. So this syndrome is especially in the patients who have got the VVI mode. Patient who develop pacemaker syndrome have symptoms of the low cardiac output. So what the cardiovascular patient will be in the hypotensive, exertional dyspnea, orthonia, palpitation, reduced effort tolerance, syncope, hemodynamically prominent neck pulses, abdominal pulsations, and the right upper quadrant pain. And neurologically, patient will be feeling a fatigue, memory loss, confusion, and the transient blackouts. The ventricular pace devices, if these patients are on the VVI mode, so that has to be converted to the DDD or VDD modes in the dual chamber devices to avoid this VVI syndrome. Now the timing of cycles, there are different timings which are adjusted. Lower rate limit, maximum tracking rate. So the lower limit is lowest rate at which the device will allow the heart to beat. If you are going to set the 60, so the pacemaker will beat, the lower limit will be the 60. Maximum tracking rate, that is set to the 120 to 130 beats per minute. Then the AV delay, so period, that is the time that the pacemaker waits after sense or the pace atrial repolarization. And the post-ventricular atrial refractory period, that is automatically adjusted in the pacemaker. This is the period after ventricular depolarization during which atrial impulses sense will be ignored. Now the additional settings which the operator has to set the sensitivity. If you are going to sense in the high, a patient is awake, he will be feeling a pinches. So the normal sensitivity voltage is 0.5 millivolt for the atrium and the 2 millivolt for the ventricle. If the pacemaker have got weak batteries, then you have to set the sensitivity to the higher level. outputs is the amount of the voltage that the device delivers to the myocardium to initiate the depolarization. Now, the newer devices are able to auto-adjust output based on the self-measured thresholds. And there are the new pacemakers which automatically switch, automatic change between the modes based on the current sense rhythm. For example, the mod will automatically switch from the DDD to VVI, GDI in response to atrial fibrillation and the flutter or SVT. So other modes, as I told you, rate response pacing. As the patient heart rate goes high, then it will be adjusted by the pacemaker. Biventricular pacing, use the cardiac resynchronization therapy to pace both ventricles and improve the cardiac function in patients with a heart failure. I will show you the separate slide of the cardiac resynchronization therapy just for your interest. Now, there are the leadless pacemakers also available. In fact, they are not available in our institute. I don't think so. They are available in other institutes in the Pakistan, but at least we don't have. These are the small enough to be implanted in the right ventricle. These encapsulated devices combine surface electrodes capable of endocardial sensing and pacing with a small battery, and can be implanted non-surgically via the femoral vein, like we are doing an angiography and putting in a catheter. Currently, pacing and sensing are limited to the right ventricle, as the device has no atrial or the left ventricular component, can do only the rate response ventricular pacing. So what are the advantages of leadless pacemakers? Low risk of infection, quick recovery, and longer battery life. They go for more than 12 to 20 years. And concern with the leadless pacemaker is not suitable for patients with a heart failure, and traditional pacemakers would have more capabilities to improve the heart function. Hard to implant the small children less than 20 kilograms, and leadless pacemakers are significant advancements in the heart care, but they have got the limitations. So let's hope in the coming years that will be as good as we are using traditional pacemakers. Now about the ICDs, implantable cardioverter defibrillators. ICDs have built an defibrillator electrode used to terminate the ventricular tachycardia and ventricular fibrillation in the high-risk patient. Sudden cardiac arrest, ICD recognizes. Now, the supraventricular tachycardias, that is SVT and AF, they are sensed through the atrial sensing, and they cannot cardiovert them. Because that is the mechanism set in these ICDs. So they only work for the ventricular tachycardia and ventricular fibrillation. But if there is a supraventricular tachycardia SVTs, then that will be sensed by the atria, and that will not cardiovert. That is a protective mechanism. So American College of Cardiology Class 1 indication for the ICD therapy is left ventricular ejection fraction less than 35 due to prior myocardial infarction, minimally symptomatic VT, and left ventricular function less than 40%, VF or the sudden cardiac death survivors, non-ischemic dilated cardiomyopathy with the left ventricular ejection fraction less than 35, spontaneous sustained VF, VT due to the structural heart disease, VT, VF causing the syncope of undetermined origin. Now, as I said to you, I will be just presenting one slide with the cardiac resynchronization therapy. So, according to the European Society of Cardiology guidelines, 2022, the ventricular dyschrony from the underlying cardiomyopathy, symptomatic patients with heart failure in the sinus rhythm with the left ventricular ejection fraction less than 30, 5% QRS duration, 130 to 149, and the left bundle branch block QRS morphology. The intended effect of CRT is to improve the left ventricular ejection by approximately 15%. CRT P is for the pacemaker also, includes the pacemaker function if needed, and CRT D is for the defibrillator and ICD function. So the left ventricular lead is inserted through the coronary sinus. Now in ICDs and the pacemakers, you will find two leads. But you can see in this X-ray, there is one lead which is passed through the coronary sinus into the left ventricle, which allows the restoration or the synchrony of the ventricles in the heart failure. So I will show you the next. Yeah. Now you can see in the pacemakers, you will find just two leads. One in the ventricle, one in the atrium. In the ICDs, you will see there are the shocking coils towards the distal tip and lead to appear opaque and thicker. But in the pacemakers, you will just see an electrode. But in the CRTs, there is a third lead which is passed through the coronary sinus. So these are the identification marks. Once you look at the X-ray, you can say this patient has got a pacemaker, this patient has got an ICD, this patient has got a CRT. So now coming to the preoperative assessment key steps. The important thing is once patient gives a history, as I said to you initially, then you have to make sure identify the device. Identify device type, manufacturer, note the model and the last interrogation date. Because this is very important to know the last date, because that will focus the battery life. Or once you are adjusting using a magnet, I will show you in the coming slides how to use the magnet, and magnet will once it is set, it will identify the battery is down or battery needs to be replaced. Interrogation reports, obtain a recent device interrogation report, check battery voltage and the lead integrity, review current settings and the stored events. Cardiology consultation, consult cardiology and reprogramming recommendations. This based on the surgical site and electromagnetic. That is all. Again, you have to consult with the cardiologist or electrophysiologist. They will let you know what to do about this patient and what are the how to fix or how they can help you to adjust before proceeding for the surgery. Patient history, document device indication and underlying rhythm, assess pacemaker dependency. The comprehensive preoperative assessment is crucial. It ensures device compatibility and the patient safety. So preoperative considerations, thorough history and the physical examination, focus history on the CID is essential. It's very important. Either patient tells you or he brings in a card or whatever, or you can talk, he gives you the number, you can talk to the cardiologist. Most patients have the information card detailing the type of device, model number, indications for insertion and the current settings. If the patient is deemed to be pacemaker dependent, secondary method of pacing patient should be established in case of the pacemaker failure. So you should have a transcutaneous pacing available. In the coming slide, I will show you what are the important things which you should have before proceeding with these patients. So preoperative pacemaker interrogation and the standard of care. The important thing is that the technician is available in the type of pacemaker, ICD, CRT, CRTP or D. P means pacemaker, D means the defibrillator, manufacturer and the model, indication, the date of insertion, pacemaker dependency, battery life, pacemaker settings, threshold check in the new leads, effect of magnet application, because some of the pacemakers, if your patient has gotten a leadless pacemaker, the magnets don't work in the some manufacturers, but some of the manufacturers that magnet works. Then the device and the lead alert recall status. If the tech is unavailable in the emergency, I said to you, look at the chest X-ray. That will give you a lot of information. The patient has got a pacemaker, ICD, or the CRT. ECG will tell you patient which type of, because in some cases, if patient has gotten a VO, you will see an pacing spike after the P wave and the white QR complex. Then if the patient has got the card, that will give you a lot of information. If the patient gives you the cardiologist number, manufacturer 24-hour helpline, some of the patients forget their patient card and they give you the number, you can call to the helpline. Last interrogation, pacemaker. Now this is very important. For the pacemaker, less than 12 months, ICD less than 6 months, CRT, D less than 3 months, because the drainage of the battery is very important in these patients. If the patient has got CRT, D, then D or P, then the battery drainage is faster or the more, so it has to be checked. Magnet application preoperatively to assess pacemaker rate changes or ICD tones. The blind magnet application not recommended unless it is emergency. So I've told preoperative assessment includes simple things always come first. Look at the chest X-ray. In the pacemaker, you will see and a 2 leads. In the ICDs, you will see and the thickness of the you can see the opaque and the thicker shadows. So you can identify this patient has got an ICD, and if the patient has got CRT, then he has got 3 leads. One is in the coronary sinus that goes directly into the left ventricle. Now, this is important decision pathway for intra-procedural CID or pacemaker. Now the surgical site above, now check surgical site is above the umbilicus. If yes, then check if the patient has got defibrillator, then check patient has got the pacing. If the patient has got a defibrillator, yes, then that has to be, and the surgical site is above, then that has to be converted by the magnet to disable the ICD. But if the patient has got ICD and the P, then the pacemaker will be working. And if the patient has got a pacemaker, then use a magnet, and that will be converted to the AOO or VOO. That will be the fixed mode. So this is very important. You should know the surgical site, where is the surgical site, and how to manage that one. Now the cycle of pre-procedural management of the cardiac implantable. So first thing is CID care center. Talk to that there. As I said to you, if you've got all the information patient is providing, or talk to on the helpline. Then the pre-procedure optimized setting, either the cardiologist or the electrophysiologist should be available, magnet should be available. Again, the leadless pacemakers, some of them are response to the magnet, but the few companies, they don't respond, the Medtronic don't respond to the magnet. Then monitoring and the emergency management. Intraoperatively, make sure you should have an alternate. If you need you need to place, so transcutaneous pacing should be available, or defibrillator should be available, and the post-operatively restore the setting as soon as possible. Now, anesthetic concern with the cardiac devices, electromagnetic interference, EMI. is the primary concern source of includes the electrocautery and the nerve stimulator, MRI or the electrotherapy. Potential effects of the pacemaker oversensing causes inhibition or asynchronized pacing. Undersensing is also risk. The ICDs inappropriate shock delivery can occur. So the magnet use should be appropriate by the either by the anesthetist or there should be a support from the electrophysiologist or the cardiologist. The magnet have a device specific effect. They typically convert the pacemaker to asynchronized mode. For ICDs, magnet application suspend the therapy. So defibrillators should also be standby available. Now, only 2 slides for the magnets. Commonly used for the pacemaker in the operating room is usually medical grade donut magnets. Size is approximately 5 to 8 centimeters and diameter. Magnet strength is more than 90 Gauss at the device. The standard medical grade magnet is 90 Gauss or greater, which is about 180 times stronger than the Earth. The Earth's magnetic field that is 0.5 Gauss. So just think about it, how the powerful that magnet is. These magnets are specifically designed for the cardiac implantable electronic devices. When placed directly over the pacemaker, the commonly converts pacing to the asynchronized mode VOO, DOO, or AOO, depending on the device manufacturer. Now, anesthetic considerations. Discuss choice of anesthesia technique and the potential effect on the device function. Hemodynamic management emphasizes the importance of maintaining stable hemodynamics. Cardiac medication. Discuss the management of cardiac medications in the preoperative period. Intraoperative monitoring. Continue ECG. As I said to you, that is very helpful to see either the patient is on the pacing or you have converted, and you can assess with the required setting. You can see on the ECG. Pulse oximetry and the capnograph. So they both are standard monitor tools. Assess the oxygenation and ventilation. Capnograph also tells you if when the CO2 is appropriate, that signifies an appropriate cardiac output. Arterial line recommended for the major cases. Also for the hemodynamically unstable patients, monitor blood pressure continuously. External pacing and the defibrillator. As I said multiple times in the previously, the transcutaneous pacing and the defibrillator should be standby. Or the transcutaneous pads should be attached to the patient. Now, intraoperative management device. Pacemaker management, reprogram, asynchronized mode, DD, as you convert to the magnet, that will convert it to the DO or VO, prevent electromagnetic interference, induce inhibition, critical or pacemaker dependent patients, ICD management, disable anti-tachycardia therapies, prevent intraoperative shocks, and achieve through the program or the magnet. So electrocautery use, normally it is recommended to use in a bipolar. If you have got in a monopolar, use short burst less than 5 seconds. Grounding pad distance from the device to the lead. Normally it is recommended it should be more than 15 centimeters. Now the response of magnet application on the CIDs. So if you are going to apply the magnet on the patient has got a pacemaker, so that will convert 85 beats per minute. But if the battery is down low, that will convert to the 65 beats, and that will shift the patient to the DOO, VOO, or AOO. If the patient has got ICD, implantable cardiovert defibrillator, suspend the anti-tachycardia therapy and anti-tachycardia pacing, and has no effect on the pacemaker function. And if the patient has got the cardiac resynchronization, CRT has got then 85 beats per minute, and if the battery is low, that will convert to the 65 beats per minute. You can there's the word written RRT, that is the recommended replacement time. So that is time you can replace that one, and that will convert to the DOO. Then the CRT-D is the defibrillator. Again, suspend the anti-tachycardia therapy. And the leadless pacemaker, I said to you, depends on the manufacturer. The Medtronic, no effect on magnet hose, and St. Jude convert to the VOO. Now the operating theater requirement, monitoring and emergency measures, ECG filters, and the pacemaker detection. This is very important that the ECG should have a filter. Pulse oximeter trace, arterial line capnograph, acid-base status and electrolyte, CVC, guide wire, insertions, coronary sinus lead or CRT, pacemakers, defibrillator pads, magnet available. Defibrillator and the pacing pad should be placed the front to back to maximum efficacy. In open heart surgery, pads will have to be placed side to side. So potential complications and the mitigations, inappropriate shock prevent by the disabling the ICD therapies preoperatively, confirm the deactivation asystole and bradycardia managed with the external pacing, device damage, reprogramming, rare but severe electromechanic interference can cause it. Proper Courtois technique mitigates the risk. Lead damage, extremely rare complication possible but direct surgical trauma. Now the post-operatively, device reinterrogation as soon as possible, rhythm monitoring, symptom monitoring, and the patient education is very important to educate the patient post-operative. So the take-home message is safe anesthesia for the patient with the cardiac device demand and a comprehensive approach, pre-op assessment, intra-op management, team approach that includes anesthetists, cardiologists, electrophysiologists, technicians, post-op reinterrogation, prompt device check, and the essential for the integrity. Now these are the references I've made this presentation. You can go through it. Update anesthesia. They are very good articles. Pacemakers and implantable cardioverts. This is then another article, Cardiothoracic Anesthesia Society South African Practice Advisory. Now, and the this is the article which is published in the circulation, peri-procedural management and the multidisciplinary care pathway for the patient with a cardiac implantable electrode. So these are the three very good articles, easy to read and easy to understand. Thank you very much. Any questions, please?
Thank you so much, sir, for such a detailed and insightful lecture. And we have a question in our comment box. Okay. Please. Starting from Dr. Zahid Shil, he asked that one of our young colleagues had an ICD fitted and he had cardiac arrest, and unfortunately he died because of failed resuscitation. Does this mean that he had supraventricular arrhythmia was not reverted by the fitted device?
No, supraventricular, they have gotten, I said to you, that is detected by the atrial lead, and they will not cardiovert in those in the ICD.
So, sorry, sir, it's me. I posed the question. Can I just say something?
Please.
Can you hear me, sir?
Yeah, please, sir.
Yeah. This fellow, I mean, it was a young 39-year-old, one of our anesthetic colleagues, and he had I think he had some sort of arrhythmia, and I just feel that he had the ventricle pacer fitted, and as you said in your talk, that if there is a problem with the supraventricular, they are not reverted. They can't be cardioverted by the device. So that's what I just thought. Since I was listening to your lecture, I thought that could be the reason, you think?
No, because as I said to you, that is an automatically built. So supraventricular arrhythmias, will be detected by the atrial leads, and that will not do the cardio.
So it should cover the whole heart, wherever the arrhythmia comes. Is that right? Wherever the fault is.
ICDs are specifically for the ventricular tachycardia and the VS.
That's what I was trying to say. So if he had this inserted, then if you have a supraventricular problem, then do they help?
No, that will not help.
So that is my question, sir. So does it mean that he could have those ventricle fitted only, but not the supra? The supra is not covered with that.
Sir, inbuilt in these ICDs, that is an inbuilt that will not affect supraventricle.
Yes. So they're just to cardiovert
only the ventricles.
For the ventricles. So the ventricles. So if this gentleman had a supraventricle, a bad supraventricle tachycardia or AF or whatever,
that could be
the reason, you think?
Yeah, but then that has to be done, the autopsy and the evidence.
Yeah. No, I know. I'm just guessing. I'm just asking the question.
You are absolutely right. But that has to be the evidence.
Oh yes, sure. Sorry. Thanks very much. That was my question. So your talk was very nice, sir. Very comprehensive.
Thank you, sir.
Very good. I've learned a lot.
Thank you, sir.
Very good.
Thank you so much, sir. We have another question. What is the significance of surgical site? Why we have to modify approach according to the site above or below the umbilicus?
Yeah, because there are 2-3 reasons. Because the battery is always there in the left side in the pectoralis major. So if the site is near, and then the use of the diathermy is very important. If you are using in a bipolar, then fine enough. Of the monopolar, then short burst, and the distance should be away from that. So these are the considerations which one has to think about before doing a surgery.
Okay, can we move on to the next question?
Please.
Next is from Adil Ashraf. How can we manage such patients in CT or MRI or endoscopy?
Yeah, as I said to you, the MRI, one has to be very careful because that has to be compatible. MRI compatible. These should be available. But in the CT you can go for it, but in the MRI there is a problem. Then you have to convert those to the fixed mode. As I said to you, with the consult with an electrophysiologist or the cardiologist.
Okay. Next we have Dr. Mohammed Yusuf Dar. He is asked that the patient is planned for lateral sphincterectomy under saddle block, having DDD setting of pacemaker. Do we need to change it to VOO setting? No cautery is needed during the procedure.
No, there is no need to that one.
Okay. And where exactly the magnet is applied intraoperatively, Dr. Adil?
Yeah, that is directly on the generator, where the generator is there.
Okay.
Yeah, you can see in this diagram, this is the generator. You can keep the magnet. Yeah, please.
Okay. Next question is, some cardiologists say magnet is now almost obsolete. Does that make some sense?
Magnet is one of the recommendations in all the guidelines. But if you have gotten a facility of electrophysiologists, they can fix it with their device, and that is also recommended. But if the things are not available, then magnet is the only answer.
Okay, sir, that was also my question, that do we have these kind of magnets available these days? Because I also heard that these magnets are now obsolete and we can't do it, and the devices that are designed, they now no longer be affected by the magnet. Is it a specialized magnet or
yeah, these are the specialized magnet. As I said to you, their volt power is 90 Gauss. And I can tell you, one of my senior colleagues, he told me he was in the army. He said he was in the CMH, and there was a patient who was electively, and they were not having the magnet, and they said they use the magnet which is used in the car deck. So he took that one and fixed that. What he said to me was one of the senior, and he said long ago he said if he come across this patient in one of the CMH in the remote areas that he used. But if you don't have a facility of an electrophysiologist who have all the devices to convert it, then that is the only answer that those patients should have, the magnet should be there to convert that one. Yes, this is not frequently available. Even I have not seen a magnet in my career, because I am working in a hospital where we call the electrophysiologists, they come and they fix it. But it is recommended. It is recommended. I shared you in a South African article in my references. That is of the 2000, I think 21, 20. In the last I showed you, and they have recommended. They have done a survey, and they have recommended the magnet should be there. This is the article which I shared in the last month's slide. So I think the magnet still has a place in the areas where, this one. So you can see Cardiothoracic Anesthesia Society. This is the article which was published in the 2021. They have done the survey in the different hospitals, and they recommend the magnet should be there.
Okay, we have a more question from Mary Khan. Do all patients need post-operative pacemaker interrogation?
Yes, I think they all need an interrogation for post-operatively once the procedure is done. Again, depends on what type of procedure you are doing, and how long you are doing, and where you are doing. But if the procedure which is where there is no use of the cautery, or you have got an appropriate arrangement, then those you don't need it. But again, depending on the procedure, then you need an interrogation. Yes, please.
Okay, next is from Nadir Adil. Sir, we should call cardiologists for intraoperative care for stable patients with ICD in district health quarter, THQ, hospital level for non-cardiac surgery?
I don't think so. You need to call. If the patient is the elective case and the anesthetist has seen all the things and he has managed, then there's no point to call the cardiologist. But yes, if the cardiologist is available, he is in the reachable, then he should be involved. Or pre-operatively, that can be discussed with a primary consultant, primary cardiologist, for any specific measures to be taken. But if the anesthetist is happy to carry on, then there's no point to call the cardiologist. Yes, Nadia?
Okay. That's all in the questions comment box. Thank you so much, sir. Thank you for such a detailed and such a comprehensive lecture, and it was really very helpful. Thank you so much, and thank you all. I have messaged the feedback form in the chat box. You can all go and fill that form so that everyone can get their certificates. Thank you so much, sir. It was really informative.
Thank you very much. Thank you. Thank you.